Hello again, this is Micah Long. I am talking more and more about mechanical ventilation here. Our rules of ICU are pretty straightforward. The blood goes round and round and the air goes in and out. I'm hopeful that this talk can put together the foundational work you've already learned by watching the vent breaths and modes lectures, and then help you apply it to the patient that isn't really doing well on the ventilator at the bedside. If you've watched those fundamental background modes, then this talk is really, really easy. And I'm Micah Long. I'm a critical care anesthesiologist who tries to take really hard to learn physiology and medicine and make it really, really simple. I blog occasionally on icudad.com. You can check it out if you want. Enjoy the lecture. The way that I'll do this is by showing pictures, pausing a moment or filling the space with some talking, and then trying to go through and identify the problem. This is a classic synchrony problem that comes up on boards and other tests for physicians all around the country all the time in different fields. And it's a classic case of air trapping or auto-peeping. And if we recall from prior lectures, if this is a pressure mode of ventilation or pressure delivered breath, you'll get a smaller and smaller tidal volume as the lungs fill up until they finally hit the set inspiratory pressure. The lungs are never fully exhaling. The second breath goes into partially filled and less compliant lungs, and the tidal volumes will go down and down, but the lungs will get more and more filled. If you're in a volume mode of ventilation, however, and you continually air trap, your lungs will get more and more inflated, but the vent doesn't really care or mind, and it will simply give you bigger or breaths on top of partially exhaled breaths, and this puts you at great risk of injury. Here's another example of what I have frequently referred to as the most dangerous synchrony problem that we see in the intensive care unit. Certainly at our hospital, our ventilators do not routinely alarm for this problem, and you can see on the screen here there's no alarm going off. And what we notice when we look at this is that it's a pressure waveform style of breathing, so there's a square wave on top. And you can see the patient doesn't really have that decelerating flow pattern we typically see. They have kind of a high effort style square wave on the flow waveform too. And then you see these two instances of doubled breaths where the patient begins an exhalation, but they trigger another breath. And in any pressure control mode, again, we're controlling the inspiratory time. And so the patient gets the set pressure that you've picked for the set time that you've also picked. And you can see here with the first event this happening that the patient gets a much smaller second breath. But on the second event that this happens on the right side of the screen, you can see that the patient makes an inordinate amount of effort and they get a much bigger second tidal volume. This is called double cycling, or two breaths before the breath is done. And it's a very common and very serious problem in critical care. Here's another example of a volume control mode of ventilation, and there's three flow waveforms shown here. Unfortunately, when I took this picture, I didn't capture the pressure waveform for this event. But on the right, you see two breaths that are both triggered by the patient. And the patient, anytime they trigger the vent in a volume control mode, will get the set volume that you've picked, in this case, 520 milliliters, over the set amount of time that you've picked, or the I time. And in this case, I don't see any exhalation between the breaths. And so this tidal volume is really over 1 liter, which is quite dangerous. This is a patient that is double cycling prior to exhaling at all. That's a very risky event. Here's a third example of the same thing, and you see on the left side of the screen a volume control or Darth Vader style of breathing. And before the patient's fully exhaled, they get a second breath in. And you can see in between the two breaths, which is shown in red, that they're not really exhaling much at all. They're holding the breath at a pause and then sucking in air again for this triggered breath. And you notice here, since we're in a volume-controlled Darth Vader style of breathing, the patient will always get the tidal volume you've picked over the time that you've picked. And you can see here why that's dangerous. You see an uptick in the slope of the pressure waveform that goes far above what it was previously. This is quite dangerous. Now, double cycling has two core types. The first is double triggering, and this is when a patient triggers both of the breaths. And they're related to patient effort. Patients making a strong effort to get a bigger breath. And in other words, the patient gets the first breath and says, that breath wasn't big enough, I want another one. Or I want more faster breaths and a higher minute ventilation, and I'm just going to trigger the ventilator every chance I can. And these are related to patient effort in general when a patient is acidotic or undersedated and agitated, or if you've just simply selected a tidal volume that is very low, aiming towards hypercapnia protective level ventilation, and the patient's not comfortable with that. These are dangerous, they don't alarm, but they're synchronous. The first breath of the event is generally patient triggered. And again, they're in patients that are more likely to have a high respiratory drive in general because of an acidosis they're trying to correct or compensate for, or because they're undersedated and the vent settings are not what they need to be. The vent settings that can contribute to this are all the guppy style of breathing we can do in modern day mechanical ventilation. Tiny breaths given very quickly with a high respiratory rate, short inspiratory times, small tidal volumes, and then flow breaths that really limit the patient's ability to get a big tidal volume with a low tidal volume being picked by you. The other one is reverse cycling, and reverse cycling is a hard phenomenon to understand, but the idea is that the vent delivers a breath and the diaphragm gets stretched, and when the vent turns itself off and it relaxes that stretched diaphragm or pulls the pressure away from it, the diaphragm reflexively contracts again. So it's almost like a second breath by the patient, except that it's not triggered by the patient. It's triggered by a reflex action on the diaphragm. So when you get a big breath, the vent releases and the diaphragm contracts to get a second breath again. This event most often occurs in over-sedate patients who are over-distended, air trapping, high PEEP, and high tidal volume patients. It's a very dangerous dyssynchrony, and it is likely more dangerous than double triggering. It's associated with lung and diaphragm injury. These are hard to identify, but if you rule out some of the double triggering phenomenon, you are left thinking it might be reverse cycling. So if you look at the patient and they seem to be working hard to breathe and breathing routinely, regularly, trying to get bigger and bigger tidal volumes, and they have an acidosis, you're probably double triggering. If the patient is very, very sleepy with bad lung disease, getting a higher PEEP strategy with a generous or so tidal volume, and the first breath in the sequence is vent triggered, not triggered by the patient is not triggering many breaths, then you're more likely to be having this reflexive reverse cycling dangerous event. Now, reviews that look at these two phenomenon and compare the frequencies suggest that reverse cycling accounts for about 1/3 of the double cycled breaths in an average patient. But interpreting waveforms is in its infancy because it involves such an amount of computational power. And so there's more we need to learn about these things. All I did is go back and show the same slides from earlier of double cycling, but I want you to look at them and try to get an idea on whether the patient might be reverse cycling or double triggering. Here again, we see a pressure control waveform, and we see the respiratory rate's 26, which is faster than the set ventilatory rate of 20. And we see what looks like a little bit of a shorter inspiratory time. We see the patient is making these efforts, and they're making that second big effort in the rightmost event of the double cycling. And we see that all of these breaths are triggered by the patient. So my guess is that this patient is acidotic and working very hard to breathe. In fact, I imagine this patient was a synchrony problem and really wanted big tidal volumes, and that was partly contributing to the selection of pressure control as a mode in general. Here's our volume control example from earlier. And here we see the double cycling event without exhalation. We see the patient initiates the first breath. That's the red-green here, the Christmas tree color. The I time is short. The patient is tachypneic with a respiratory rate of 30 despite a set respiratory rate of 20. So this again is likely double triggering. Here's the next one, and I have to apologize. This is taken from a journal article I've cited below, which is one of my favorite journal articles for reviewing these desynchronies. But I apologize because the flow is on top here, and we've been looking at all waveforms where the flow is in the middle. So you have to reverse your thinking for a moment. And we see that these are Darth Vader breaths with escalating pressure waveforms. And as we look, we see that after the first and third breaths, the patient has this unusual expiratory waveform where they thumbprint, or they almost looks like they try to suck in air in the middle of their exhalation. I call that thumbprinting. And this patient thumbprints breath 1, breath 3, and then on breath 5 you see that they finally successfully thumbprint enough where the flow moved positive to the flow trigger, and they get that second delivered breath. And you see on the pressure waveform, the pressure went up with a steeper slope of the pressure waveform, so this was a dangerous breath. When we look at this a little bit closer, what we see is that all the breaths are vent triggered. I'm guessing it's not listed here, but it does not look like there's a slow escalating airflow before the breath, and it seems like they're riding a fixed respiratory rate here. And the vent rate is fixed despite what looks like the patient trying to breathe again and again in exhalation. And that supports this not being double triggering, where they'd be trying to breathe in every chance they get. But really, that this is more likely to be reverse cycling, where the breath is really a reflex contraction of the diaphragm. Here's a textbook example from the web that I found, where they really call this something unique. And I bring this up because this makes it hard to learn about desynchronies by names and nomenclature, and you really have to look at waveforms themselves. And here, when I found these waveforms printed out, they called this premature cycling and blamed it on a faulty inspiratory time. But here we see the exact same thumbprinting expiratory waveform, like the patient is trying to breathe in or suck in air after their first breath is done. And what was taught on this website is that this is because the I time is too short or the tidal volume is too low. And both those things may be the case, or it may be that this is a reverse cycling event and this is patient independent diaphragm reflexive contraction that just hasn't succeeded into a double cycling event yet. And that's called premature cycling in some texts. I like to think of it as an attempt at a double cycle event. When I look at this waveform, it's very hard for me to get an idea of whether they're double triggering or reverse cycling. It doesn't look like the breaths are patient triggered, but it's hard to tell sometimes. The I time, this isn't my vent. I don't know if it looks short or if the tidal volume is very low. But I would look at the patient and make a decision on whether they are riding the ventilator over sedated or whether they're working hard to breathe with acidosis and trying to get bigger breaths that are and raise their own minute ventilation. If they're trying to get bigger breaths and raise their minute ventilation and trigger as frequently as they can, this would be likely to be a double triggering event. If they're very sleepy with bigger tidal volumes or higher PEEP, in this case it's just 5, but if we were at a PEEP of 10 or 12, I would worry a little bit more about reverse cycling, but I can't tell in this picture here. Here's another example of a confusing one. We have flow on top and pressure on bottom, so reverse your thinking here for a moment. And on the left we see this thumbprinting, but it doesn't occur right after the breath ends. And we see that a little bit on the right as well, this very late attempt at double cycling, or the patient trying to take a breath in before they've fully exhaled. But in this situation, it's not occurring right after the breath is done. It's occurring late in exhalation. When I see that, I think the patient might be trying to double trigger and raise their minute ventilation by raising their respiratory rate. Alternatively, they could be trying to auto PEEP. And if you have a PEEP that's set too low in this situation, I can see on the leftmost pressure airway that their PEEP is somewhere around 1 or 2. They may in fact be attempting to auto PEEP themselves, no different than when a patient with COPD has pursed lips breathing. And on the right, I see a similar thing. Not that the PEEP is low, but that the patient's making a later inspiratory effort later in exhalation than our typical double trigger reverse cycling. So if I were to make a guess at these waveforms, I think the left panel is a patient attempting to auto PEEP themselves, and I think the right panel is a patient that is trying to double trigger because they're acidotic or agitated and they want a higher minute ventilation. All right, shifting away from the double cycling challenges, what we see when we look at this waveform is a pressure control style of breathing with a square pressure waveform on top, and then a flow waveform that has that nice normal decelerating pattern. In this case, it's Christmas tree colored, so it's triggered by the patient. But we see the flow decelerates and it decelerates to 0, and then they sit there for a while before they're allowed to breathe out. And this is a case of an inspiratory pause when the inspiratory time is set too long. This isn't necessarily bad, but in this situation we see that they have a high PEEP of 12, or generous PEEP of 12, and they have a high FiO2 of 100%, which makes me think that maybe they are trying this strategy as an attempt to recruit the lung. And there's really better ways to do that than holding a high inspiratory time. And so I would adjust this and probably just go up on the PEEP. In this situation here looks quite dangerous, however, because the pressure control above the PEEP is already 23, the PEEP is 12. That high of a driving pressure with high PEEP is not a good situation. So it might be that everything's been tried in this patient, it's just not working, but I would be trying alternative strategies for this patient. Here's an example of a pressure-delivered breath, which you can see by the square wave blue waveform on top, and then a nice decelerating flow waveform in the middle that looks like they're taking a very short inspiratory time and cutting off that breath really early in that area under the curved pyramid we think about, or the triangle there. And then we see that they have tons of expiratory time that they're not really using. Patients getting a breath and then kind of resting there, and then getting a breath and kind of resting there. And when I see this, I think that you could increase the inspiratory time and really gain some of that area under the curve, under that pyramid, without risking air trapping, because you have so much extra time here. And what that would let you do is get a bigger tidal volume here so that you could lower your pressure, your driving pressure here, and get the same tidal volume. So same tidal volume, lower driving pressure, sounds like a good deal to me, and seems like the right answer here. Here's another example of a unique problem that I see less frequently, but certainly with regularity. What I notice here is a flow pattern and a pressure pattern that both look kind of like square waves, so I don't know what mode of ventilation this is. But I do notice that at the tail end of the breath, the flow goes negative while the pressure is still being delivered. So that really suggests this is a pressure breath with an inspiratory time that's longer than what the patient wants. And so the vent is delivering this fixed pressure for a fixed amount of time, and the patient comes along and decides, wait a second, I'm done with this breath. They start to breathe out, but the vent is still delivering positive pressure, and so they fight that pressure. There's a little late peak in the pressure, the flow goes down, and finally the vent relents, and the breath continues. This is called delayed cycling. The patient is trying to breathe out before the I time is done. You've cycled or turned off the breath too late, or in a delayed way, delayed cycling. Simpler way to say it is your I time is too long. Now here is a problem I see routinely when people flip over to volume control modes of ventilation. Volume control modes of ventilation can be delivered either as a Darth Vader breath, as we've talked about before, or as this nice decelerating waveform. Here we see volume control in the top left, but we see a waveform that looks like a pressure control waveform. And that gives it the mode away. It's a volume control breath with a decelerating waveform. Very nice for air-hungry patients because it delivers a high peak airflow rate right at the start of the breath. The problem being that this patient wants more flow than that, and the flow is fixed. The vent isn't giving more air. The vent gave that set amount of air, and the patient is trying to suck in air, and so when the breath starts, they get this little peak in the airway pressure. But then the patient tries to suck in air, and they're sucking in air so hard, so much negative diaphragmatic pressure to try to get a bigger tidal volume that it's pulling the pressure waveform negative. But they're not successful, and they're not successful because in a flow pattern of breathing, the vent will give you this tidal volume, in this case 420 mils. It doesn't care that you want more. You're getting 420 mils. It's what's being delivered in that nice triangle, and that's all. So you can pull all you want. It will be very uncomfortable, and you'll get this thumbprinting of the inspiratory pressure waveform. This is a flow-starved pattern. Again, the patient is sucking in air so hard it pulls a negative pressure. You can fix this, but most of the time when you're trying to fix this, you simply have to tolerate a larger tidal volume than what would be typically considered lung protective. You could try to give an increased flow with a shorter I time or give them a high peak flow rate. That frequently doesn't work. You could do a volume control mode and make the tidal volume bigger, or you can sedate the patient more so that they have less of a strong drive to breathe here. This is a flow-starved, very uncomfortable waveform. Here's another example where we have a PRVC, or a pressure-delivered breath, but where the pressure-delivered breath should look square, it's not at all. It's in fact pulling negative below the PEEP and then popping positive at the tail end of the breath. This is a situation where they are pulling so hard to breathe, they're pulling a negative pressure below what the PEEP is, and then at the tail end of the breath, they're trying to end the breath before the inspiratory time was hit, and so this is likely also a delayed cycling. Your I time is too long, and they're working too hard to breathe. This is a good example of when PRVC goes wrong. The vent here, if we look at the tidal volume, the patient's pulling around 600 mil tidal volumes, but the set tidal volume is 480. And so the vent will say, oh, tidal volume is bigger than what we've set. We need to wean the P high. And so the P high will go down all the way to PEEP. The patient will breathe unsupported. And in this situation, that peak pressure comes at the tail end of the breath because they're just done with the breath. It's time for them to breathe out, and you set the wrong inspiratory time. This is an intensely uncomfortable and unsafe way to ventilate somebody. This flow pattern I've included because it's worthwhile to glance at. We see a rhythmic, fast stacking of waveforms with no change at all in what they look like. This is auto-cycling, or what happens if the vent's disconnected. Here's another example of a flow waveform or volume control breath with a decelerating waveform selected. We can see that on the middle waveform. And the top pressure waveform has this huge thumbprinting in on the breath, and we know that this is a flow-starved waveform. The breath starts, and then the patient sucks in air so much the vent pressure can't keep up with it. You can fix this by, of course, flipping to pressure modes, but then you're going to have to tolerate a much bigger tidal volume than what you're getting now most of the time. You can also over-sedate the people so they have less of a drive to breathe. Here's a volume control, decelerating flow with a tidal volume selected of 520 milliliters. And again, we see this flow-starved pattern. I took a bunch of these pictures because I had a spat of flow starvation in a week that I was on service, where I had to really do a lot of ventilator adjustments to make things work. And oddly, I haven't seen this pattern the last several times I've been on the unit, so I don't know, bad things come in packs. But here we see again that flow starvation pattern, and then the patient seems to give up at the tail end of the breath. And so maybe in nighttime that's too long.